easier to deal with from the provider perspective.
Okay, thank you, all of you.
Now, there's a reason I wait till the end.
Got anything to say?
Oh. Eh, But poor Ms. Moore has had to deal with me on Ways and Means for many years on my,
Really miss you.
on my fixation on this subject. And, part of my goal is basically to annoy everyone and try to.
That's why we're here, because we want to be annoyed.
No, I mean it with love. Okay, a quick observation. You're all freaky smart. And yet you do realize some of the ideas you have are conflicting with each other in model and design. And maybe there's a need for enough optionality in what is U.S. healthcare. I do want to just rattle through some questions, and then I want to do a what if with all of you. And the beauty of it is playing chairman. It took many years to get to this seat. I don't have 5 minutes. I have as much time as before you basically get annoyed with me and run out the door. Mr. Tingle, think about, and we'll disclose, we have some very common friends, and those things have been talking about everything from blue zones together and other things. But you've been doing some of this project of helping your participants stay healthy for how many years?
Just past 10 years.
Okay, so you have 10 years of data. What is, if you had to think of all the little things you've done, from gamification to a reward here, to a premium value, to what has been your biggest failure, but it's also what's been the biggest success? I'm sort of curious, you have 10 years of data, you have tens of thousands of lives, you've been doing sort of experimenting, conceptual experiment. What's worked and what hasn't?
Well, the biggest very pleasant surprise to some, not to me, is that behavior change is achievable. There are lots of people that are very cynical about behavior change, and we all know it's hard. I not as good at changing certain things about my choices as I should be, right? Like, change is hard, but you can affect population-level behavior change through incentives, rewards, education. We've seen it time and time again. Our program would be far less than we sought out for it to be if all we did was just attract healthy people. We want to meet Americans where they are. You need to lose some weight, you need to lower your A1C, whatever it may be. Meet you where you are and give you the tools, the technology, the support to improve. And we've seen time and time again, we see people before they join the program and after they join the program. Physical activity, adherence to screenings, you can change.
But I'm being, and I don't want you to give away trade secrets, so tell me it's a trade secret, but okay, what surprised you saying, hey, this actually has changed behavior? Hey, this incentive here didn't work. Because you started to allude to that some of the gamification seemed to have more participation than the dollars over here. Help me walk through that.
Sure. By far the biggest surprise is what people value, and honestly, just how small of an incentive many of us will respond to favorably. I saw a study by a consulting firm recently that said what's the average size of an incentive that an American will respond to is $1. I don't know if that's true or not, but we've seen in our program, again, by far, the most popular element of the program is one where people play this game and win, $5 at Amazon, $10 at Starbucks, where they're saving thousands of dollars on their premium or enjoying all kinds of other rewards. So the engagement, the digital engagement, the technology, harnessing the power of all this information. I will tell you also, the power of the wearable technology and other technology, when we launched this program, there was no Apple Watch, there was no Oura Ring, there were none of these things. And now they're so common. And our part of our goal is to make them available to more Americans. We subsidize the cost of those things to reach more people with them.
Okay. Part of the reason for asking this question, this was also to share with my brothers and sisters up here on the panel. I have a paper, it's a few years old. Greatest success we had in the last 20 years of young people actually getting out and getting somewhat healthier, because we spent billions and billions and billions with Michelle Obama's outreach concepts and those things and changing lunch. It turned out to be Pokemon Go. Mm-hmm. And you sit there and go, well, that's absurd, but there's a really good paper talking about the physical activity. And maybe we undervalue the concept of gamification in incentives, particularly, you have the ability, whether it be this, of, delivering that, and it's additional incremental cost. And we've actually been experimenting with some designs of, okay, Obamacare, ACA, and look, it's 7% of the market, this and that, but it's, 3 age groups and smoking. Could I ever add a 5th tier that is a lifestyle positive reimbursement sort of and build from there? And so, it's just continue to conceptualize these. Dr. Clark, as you know, I've personally grown very fond of the things and some of the creativity coming out of Banner. But I need to work through some of the model I've worked on since I was 28 years old in the state legislature, and by accident ended up chairing the health committee. They indicted 10% of my population, so I moved up really fast. It's a great story. And back, you don't want it. But even back then, Arizona has a quirky Medicaid delivery system. We functionally buy managed care policies for our poor. And today it's almost approaching, 25% of my state's population now? But if I came to you and said, oh, great, here's Medicare Part C, many of you think of it as Medicare Advantage, that is the original design has become a little distorted because of some of the ways we've scored sicker and we do some of the star ratings, and I'd love to get it back to its original design where an insurer is benefited financially by having healthier populations, but that's a managed care model. My state employees in Arizona functionally are in managed care models. My 25% of my population, technically we use the term indigent, is in a managed care model. Many of my state retirees, university retirees, and those are in a managed care model, and many of my private insurers can buy into a capitated managed care model. Even though they're all different payers, that's the majority of my state population in Arizona. The robustness of a network where I'm sitting in a waiting room and I don't know if you're on my state's Medicaid system or you're a state retiree or this, does that provide the ability to have continuity of care, because I may move up and down or to retirement in my delivery system? So how do I get that sort of model of my hyper-efficient delivery system and many of the incentives Mr. Roy, who I'm a big fan of, develop in the purchase? And I know I wanted this not to be about healthcare finance, but I'm sort of dragged back there for a moment. And then we're going to go talk about my utopian technology. Is there a path here? We're saying, look, we have all these populations where we get rewarded as the insurer or the healthcare provider by having healthier populations. And here's the optionality Mr. Roy talks about of my choice and purchase and the type of plan. Help me.
Yes, that's a tough one. So let me build on your the scenario you painted of a waiting room of patients there who might have multiple different insurance plans. So if I'm a delivery system, and let's just take Banner Health. So I'm one of the primary care providers or a specialty provider who's in charge of that waiting room. That's my clinic. It is challenging right now when each patient potentially has different insurance plans with different reimbursement rates, different value-based quality measures that which are well-intended to do the right thing, but also have very short terms. I wasn't aware I was such a big fan of the Swiss, and I learned they have the 3-year term, which is one of the things that we're very keen on in a Medicare pilot, yes, because a lot of the stuff we're talking about, the questions about prevention and screening and other things, and specifically making sure that you have enough time to get to know a member and continuity with them. It's really maybe towards the middle or end of year 2 that you're really going to start to see some of these savings start to hit.
Dr. Clark, I'm going to step on you just a bit because remember, I partially stole this idea from you. So we have rewritten a piece of legislation to try to fix the anomalies. If any of you read the MedPAC report, it's almost, and we have 6-7 years saying the same thing, that we have almost $2 trillion of misalignment, fraud, bad design over 10 years. And one of the things the actuaries, and they were kind enough to be actuaries also from Banner, said, if someone chooses to roll with almost 55% of the US population now in a Medicare Advantage plan, choose to say, I'm gonna design this plan, my enrollment is for 3 years, I can opt out annually, but my enrollment, does it change the investment you will make in that person in helping them get healthier, to help them manage their BMI, to help them have technology? How much does that, if you knew you had a life with you for 3 years, change your investment in making that person's life better?
Yes, it would dramatically increase the chances of making that investment, because a lot of these things do take multiple years before you see the return on that. And it is challenging if members, whether they're Medicare Advantage or otherwise, switch plans every year. Not only may your providers not be in that network anymore and may not be able to render care on them too, but it takes a while to develop a relationship, make sure they get the screening tests done, build a relationship with a nurse care manager. Perhaps there are social determinants of health which need to be addressed as well. We invest in social workers to help folks with those things, but these things take time, right? And so we are absolutely more likely to invest in those things with a longer runway. And it's not just because we're looking at, is the ROI not going to hit at this date? It's because clinically, sometimes that's how long these things take. If you control, if you take a cohort, let's just take Medicare Advantage patients, if you control their blood pressure, control their diabetes, tightly manage their CKD and other things, we can have a significant impact on lowering the avoidable admissions for those conditions, which contributes to a significant amount of medical costs. But it takes frequency and continuity of visits with your primary care team and the coordinating specialist to make that occur. And this could even be up to a visit every 3 to 4 weeks with some of the patients who are in the highest risk bands, who might have multiples of those chronic conditions, and also may just have trouble navigating the healthcare system. So we're actively investing in the data to inform our care teams about who are these folks, and then bringing in other staffers and team members, because this is a team sport now. It is not go to medical school, do residency, hang a shingle, start operating, or see patients on my own. You have to have a team with you, and it costs money to set those things up. The last thing I'll say about a longer term is it also means we have continuity of the data at minimum over 3 years. Because when someone decides to attribute themselves to our accountable care organization, it's not until about March of that year that we actually start getting their claims data to flow in, to drive the analytics, the AI, and everything to say, hey, here's a patient who has high risk for adverse events. If we've had 2 prior years of experience of claims coming in, HIE feeds, lab feeds, all these other things, we've got muscle memory knowing who that member is and can make sure that we're keeping close with them and wrapping all those services around them. So the longer 3-year term, I think, is a very important part of how we look at this going forward.
Mr. Roy, how do I make that work?
Well, my favorite idea for liberating healthcare and creating a lot of the incentives that Mr. Chairman, you've been talking about for so long, is to effectively say that for the top decile of people in the Medicare program, in terms of lifetime earnings, that we say, no, you know what, we're not going to ask middle-class taxpayers to subsidize your healthcare costs. Go get your own insurance or get your own healthcare. And 1/10 of the Medicare population is, let's call it 6 million individuals, 6 million seniors. And all of a sudden, you'd have this massive population. 6 million is fairly large because these are older individuals that consume a lot of healthcare. But then you have this ability to rethink how we cover and care for those individuals from the ground up using 21st century technology. So all the things that you've been mentioning, what about wearables? What about artificial intelligence? What about new modalities of care? You'd be completely freed from the way employer-sponsored insurance has worked, the way Medicare has worked, all the things doctors get paid for or not get paid for. You could completely reimagine it from the ground up. And that could lead to a lot of the positive incentives in terms of healthy behavior that you're looking for. Go ahead.
No.
I was going to say, the one last thing I will say on this topic is it's really important to appreciate that prevention doesn't necessarily always lead to lower health costs in the long run, because we all have to die of something. So maybe that individual doesn't have diabetes, but they might get cancer later, or Alzheimer's disease, or bust their hip, right? So mortality is the one certainty, right? So even if you want to have a cheap healthcare system, the best way to do that is for everyone to die of tuberculosis at the age of 30, and I promise you'll have a low-cost healthcare system. But obviously, that's not what we're looking for here. So there's a degree to which I want to make sure that we all understand that prevention is good for public health reasons, but sometimes that may also lead to more expenditures.
Yeah.
So that's okay.
And Mr. Roy, and whether you remember or not, you and I have actually had part of this conversation because I've always wanted to redefine the definition of prevention to be a revolution in the management of chronic conditions. I despise one of the things we've done in U.S. healthcare is we finance your misery. We finance you managing your the 5% that's 50% of healthcare, instead of also doing those things that are curative. And we're going to come back and talk about the fact we're on the cusp of revolutions of we can cure hemophilia. We're almost on the cusp of some major changes in diabetes, the ability to maybe reintroduce undifferentiated islet cells and some of these things, which would be revolution of ending the management of misery to the curative of it. Dr. Fiedler, what do you think of Dr. Clark's sort of managed care model with the capitation where the incentive is health and utilization? Does that work in your model?
I'm generally of the view that certainly moving away from pure fee-for-service is a good idea. I think the hard question is, do you want to go all the way to capitation, or does that end up giving the provider excessively strong incentives to ratchet back utilization? I think there's a balance, and I think my view is probably in most instances, the goal is a sort of partial capitation model where you have some amount of fee-for-service and some amount of
So you're
capitation.
comfortable with sort of the graduation risk-sharing model of once you hit a certain threshold, you owe 95, the risk covers 5, and it slowly steps out?
Right. I think it's absolutely the case that pure fee-for-service is obviously the wrong answer. And is if you think about an ACO type model where there's a shared savings rate, is that right shared savings rate 50%, 75%, 100%? I think they're like reasonable people can disagree, and I'm honestly just uncertain about what the right answer is there.
But we've actually had one of our healthcare economists sort of look at where do you get the highest price efficiency here, so knowing what, as a provider, what your risk is, but also making sure it's not a cliff so there's no dumping, as we saw in the early years of even my state's Medicaid system, when you hit the threshold saying, oh, damn it, just spend the next $10,000 and get them to the threshold, because then there's the state's problem. So we needed to make sure there was constantly sharing of risk. Okay, now a little bit of utopianism. Dr. Clark, if I came to you right now and said what you see your vision of the next few years, so the gentleman sitting next to you has an Apple Watch that is FDA approved for the heart. He's wearing an Oura Ring. If he threw his Dexcom on, he'd have his blood glucose. He's basically, besides being the CEO of a wonderful company, is also a walking medical lab. Does that make it so you could provide healthcare services and maybe almost minimal human interaction because you have latitudinal data from him 24 hours a day, 7 days a week, and would know if something's happening? How does that type of technology over the next few years change the fact that, actually, Ms. Fiedler actually touched on it, we have a shortage of medical professionals. We have a demographic issue. I have the same number of 18-year-olds today as I had 20 years ago, and double the number 65 and up. We're going to have to deal with the reality of it. The United States has a high likelihood of having zero population growth this year. How are you going to substitute for the lack of healthcare talent and do it with technology? Does any of that work for your future of your model?
Great question. Yes, it does work, and I think the model's going to depend on it, especially going out longer. To your point, well, there's not as many folks going into primary care, and we do have an aging population, so we do need these systems to help scale rendering primary care. Figuring out the role of AI. I know there's legislation that prevents us to use that for diagnosis, except in maybe a few cases.
And I will do everything I can to stop that.
Yeah, and there's certainly risk. We all need to go into that carefully, right? But no, we absolutely are going to need to depend on those types of systems being there. When I talk about prevention, to your point of how we change that, I'm generally thinking, did we prevent somebody from an unplanned visit to the ER or the hospital? That's how I look at what I'm asking our primary care teams to do. If there are wearables, and I've been getting pinged by Oura Ring telling me to stand up here a couple times here, where it can send a message seamlessly to a patient specialist or coordinating PCP team to say there's an arrhythmia here or there's something going on, that is valuable. I mean, we're trying to create that now through phone calls or iPads or other things where we're asking the member or somebody on these lists to reach out to us. It needs to be the other way around, where we reach out and ping them, or the device automatically sends a message to that team, and a nurse care manager anytime of day or night can pick that up and route that to somebody who can triage that to the next step. So, I think the risk would be what we have to figure out is there's going to be a lot of different things and a lot of noise. So how do we get that down? But we're going to be dependent upon this.
And just because I'm already starting to cross over the committed time I made to everyone, let's do something that's not necessarily Republican or Democrat. There apparently is an agreement that in the next few months, there will be an oral tablet glutide coming. And its price will be $149 a month. We've been trying to do some back-of-the-napkin math of what that would mean to my state's Medicaid system. If the majority of my state's Medicaid system is technically, its BMI is obese, what would happen at the end of 2 years if we helped our brothers and sisters get healthier? And look, diabetes, obesity, they're complex. We've learned there's autoimmune issues, there's more to it. But let's actually take a look at, I'm going to go with you, Dr. Clark, and then let's see who else is daring enough to comment on this. We've already done our economic study showing that obesity is 9.1 trillion additional healthcare spend in America over 10 years, making it the single most expensive thing in our society. If the glutides are about to become functionally 20%, 18% of what they were 1 year ago in price, what does that do to change the future utilization of those with multi-chronic conditions? And where this partially comes from is we have the Milken study from a few years ago actually, saying 47% of US healthcare is associated with obesity. We know 33% of US healthcare spend is just diabetes. Are we on the cusp of a moral solution that could dramatically change the price of healthcare?
I think yes. The literature shows that just if you isolate diabetes and show that you're controlling the blood pressure of those patients, you're improving their A1C control, you're putting them on statins, just that alone has significant impact on some of those things I spoke about earlier. It delays blindness, progression of chronic kidney disease, avoidable hospitalizations, all those things, dialysis, right? So if we just focus on that alone, the benefit that it could have, that could be amazing. We continue to learn in the literature, and it's hard to keep up because there's so much that comes out about this class of meds, other protective benefits it has too in other areas. So if drugs like that are out there with a favorable side effect profile where we can go out with them at scale, could have a wonderful impact on the US healthcare system. And the other thing too, to one of my concerns, we don't have enough primary care doctors to take care of our folks in Arizona. We did a survey on our network some time ago and found that a very high percentage of them are going to be over 65 very soon. And so again, if we're not having to worry about the complications of obesity and diabetes quite as much because it's better managed through these new innovations, that demand on the PCP can somewhat be relieved as well. So I think there's lots of benefits there.
Anyone else dare to go close to this? Mr. Roy.
I have 4 bullet points for you on this topic. The first is that the reason we don't have a physician shortage. We have a primary care physician shortage. The reason for that is this thing called the RUC committee in Medicare, which basically pays specialists more than primary care physicians due to, basically who has political power within the AMA. So that's something that Congress can fix. That's number one. Number two, there are statutes, the Stark statute and the anti-kickback statute, that basically make it very hard for technology to be interoperable in a way that that people can monetize and entrepreneurs and innovators can monetize. So we have to revisit Stark and anti-kickback laws and modernize them so that technology can be more interactive within various healthcare providers. The third thing is AI. So right now, if you have a primary care shortage and you don't want to fix RUC, the other thing we can do is use AI to enable nurses and other physician extenders to practice to the top of their licenses. And let's also reform the licensing laws that unfairly restrict, with a guild mentality, what nurses and extenders can do. So that can help address some of the shortage. And the final thing I'll mention is that when it comes to drug development, one of the real mismatches that we have is that drug companies can basically charge $1 million per patient per year if they develop a drug for a super rare disease, but they can't for diabetes because it's a more competitive market. On the flip side, the clinical trials for a rare disease are much cheaper than for a large disease like diabetes, because the FDA will make you do a trial with 50,000 patients and 5 years of outcomes data that costs you literally $2 billion to run. And so what do pharmaceutical and biotech companies say? They say, well, I don't want to develop a new diabetes drug or a diabetes treatment because I'll have to spend $2 billion developing, and if I'm wrong at the end, I'm out of luck. Whereas if I develop a drug for a super rare disease that only 50 people in America has, I can make the same amount of money, but my upfront risk is lower. So that's something we have to revisit if we want to actually create an innovative ecosystem that's addressing common chronic diseases like diabetes and heart disease.
All right. Lightning round. Anyone else first on obesity willing to comment? Then, Mr. Clark, are you familiar with concepts like Civica RX? At the co-op.
No, can you give me some background on them?
Mr. Roy, you're familiar with my fixation on, we play this game here. PBMs are evil, PBMs are fine. Drug companies are evil, drug companies are fine. Retail pharmacies are fine, they're evil. And I want to argue that we're on the cusp of a revolution happening right now, where I see major pharmaceutical manufacturers selling directly to consumers. I see Medicare, Medicaid systems, hospital systems, insurers coming together and making their own. And that's what Civica RX is. They're making 3 types of generic insulin that is cheaper than the subsidized price we produce from the federal government, where we subsidize. But I've even had a presentation a summer ago of a company that's doing 3D printing of drugs. So at your hospital system, here's your generics. You put in your orders a week or two ahead, and you just print them right there. Mr. Roy, you're familiar with some of these concepts. Are we on the cusp where we're having the wrong debate because we're debating last decade's siloed systems, and is technology about to change everything from the way we do health management with technology to the way we actually even access our pharmaceuticals?
Here's the biggest problem on the drug side. The biggest problem on the drug side is that we have a completely different statute governing generic competition for what are called small molecule drugs, old-fashioned drugs that you can synthesize in a chemistry lab, and a completely different statute to regulate off-patent competition for biologic molecules that are engineered and manufactured in living cells. That's Title VII of the Affordable Care Act, which is called the Biologics Price Competition and Innovation Act of 2009. The pharmaceutical industry basically put all sorts of subtle kind of time bombs in that bill that basically make it a lot harder to develop generic biologics, we now call them biosimilars, that would then drive down the price of those drugs when they go off patent. So as a result, we're not seeing cheap generic biologics in the same way that the Hatch-Waxman Act on the small molecule drug side allows us to have commodity pricing when a drug goes off patent. That's a huge win for public health. When Lipitor goes off patent, all of a sudden, less than cheaper than this bottle of water, everyone can have basically free cholesterol-lowering drugs. That's a huge win for public health. We're not doing that on the biologic side, and the consequence of that is today, 54% of spending in the U.S. on prescription drugs is for biologic drugs that represent less than 4% of prescriptions. 91% of prescriptions are for generic drugs, And then 9% of prescriptions are for branded drugs. And of those 9%, actually a very small percentage, really less than 1%, drive nearly half of all drug spending. And that's because Congress made it hard for us to develop generic competitors to those drugs.
I think I hear a piece of legislation somewhere in there.
Absolutely.
Anyone else have some other thing, Mr. Tingle? And then we're going to move to shutting down.
Yeah, I would just, first of all, thank you for your passion on these topics. But I would not overlook, there's amazing stuff coming, the power and potential of regenerative medicine, all kinds of things. But we have things right in our hands now. You just talked about GLP-1s. We have early cancer, multi-cancer early detection tests. And we all, private and public folks, need to be working to get these into the hands of the people that are going to benefit them. Because a few years ago, these things were unthinkable. Now we have them. They're amazing tools.
I want to thank all of you for giving us as much time as you have. Do be prepared. I can already see a couple of the team here have all sorts of questions for you. You've all been actually remarkably intellectually forthcoming, and it's appreciated. And with that, this hearing is adjourned.